From today we are going to start with the surgery, and first of all I want to say that this is the operation theater where we perform the surgery. Okay, so the operation theater is almost a sterile place and with no infections. Now we know that surgery and anesthesia alter the normal physiologic and metabolic states in a body. So and also the point is that comprehensive history and physical examination are necessary before performing any surgery. Okay, now we know that there is an preoperative evaluation of a patient which should be done, and we will start with checking the hemoglobin in. Like the hemoglobin is the test for hemoglobin, like CBC, is performed in the patients in which there is more than 500 ml bleeding, like which is predicted the patient is to have more than 500 ml bleeding, or he has anemia, or there is a suspicion to anemia. Okay, and also patient with metastasis, any patient with a kidney failure or kidney diseases, any patient with a cardiac disease, diabetes and pregnancy. Okay, these patients are which have to undergo check for the hemoglobin. To check the electrolytes, we consider the patients who are using the long-term diuretics, like who have been using the diuretics for more than 2 months. Any chronic disease, if a patient had any chronic disease, like there can be any rheumatic disease, or there can be any kidney or chronic liver disease. So in these patients electrolytes are checked, or there is any history of uncontrollable vomiting, like the patient had an episodes of uncontrollable vomiting, and patient are elderly, they are elderly patients. Okay, now the test for the urine test should be performed in patients who have urinary symptoms, or any chronic urinary disease, or the patients who have to undergo surgery for the urologic procedures. Okay, for the urinary system. Now the patient is considered asymptomatic if investigations are normal within 4 hours. There's a patient has undergone these type of tests, and now he has to undergo a surgery, and within 4 months he had these tests which were normal, so he doesn't need to undergo any of these tests. Okay, now before surgery there is a consultation, and this consultation is to evaluate the risk of the surgery in a patient, and also planning for the success of surgery, and also better recovery after surgery could be achieved. That's why we have the before surgery consultation. After surgery consultation is if some unexpected complications arise. For example, we give nephrology consultation to a patient if he has oliguria or increased creatinine in urine, even after we have given him sufficient fluids. Okay, after the surgery. For example, also similarly cardiology, like we give cardiology consultations to the patients who have who developed, for example, myocardial infarction after this surgery. Okay, now some assessments, like for example we have to do the cardiac assessment, similarly we have to do the pulmonary assessment, we have to do the kidney renal assessment, we have to do like liver function assessment, and similarly we have to we have to be familiar with certain conditions in surgery, like diabetes, like pregnancy. Okay, like adrenal insufficiency, and then we will go through the tubes, like what are the tubes that are used in surgery, then wound infections. Okay, then wound infections or wound incisions, like how we manage the pain, how we prevent DVTs, deep venous thrombosis, and also some of the post-operative complications which we come across. Okay, so this is a general thing that we will learn about some investigations like we did, then cardiac assessment, pulmonary assessment, renal function assessment, similarly hepatic function assessment, and some conditions related to the surgery like diabetes in surgery, pregnancy in surgery, steroids in surgery, and then some instruments like tubes, which tubes are used in the surgery, and then management of some common surgical problems like the pain, the wound infection, or fluid resuscitations after that. Some post-operative complications also like atelectasis, like fever after the surgery, etc. Now we have been done till cardiac assessment, like for the before surgery consultation we have to evaluate for the risk, and after surgery consultation is given to the patients who underwent some unexpected complications after the surgery. Now for the cardiac assessment, like what are the effects of first we have to know that what are the effects of surgery on the heart of the patient. Okay, when there is during surgery there is a stress and there is increased catecholamine released. Okay, and this catecholamine release increase the oxygen need by the heart. Heart needs more oxygen during the surgery. That's why we give this patient with oxygen mask during the surgery. Okay, then there is also some kind of physiologic change in which the fibrinolytic system is like suppressed. Okay, fibrinolytic system is suppressed so that the wounds can heal or bleeding can stop, but this also increases the risk of thrombosis. If fibrinolytic system is suppressed, there is a risk of thrombosis. Similarly, we group the patients into low risk and high risk. In the low risk patients there is no cardiac assessment required, and in high risk patients or those patients who have had some kind of coronary heart disease, arrhythmia, peripheral vascular diseases, structural cardiac diseases, or like some tests, and like some tests should be done in high risk patients for the cardiac evaluation, like cardiac function assessment. So these tests are like we should do ECG, we should do echocardiography, or the stress test. Okay, these tests should be done in these patients. So this is the cardiac assessment. Now for pulmonary functional assessment, and there is like we do not perform any pulmonary tests or say chest x-ray before performing surgery, but except such x-ray is done in the patients who already have a history of some active pulmonary disease. Okay, and also in patients who are undergoing intrathoracic surgeries, like thoracic surgeries are to be performed to the patient, so chest x-ray is to be done. Pulmonary functions test is done in the patients who have risk factors of the pulmonary complications after surgery. For example, who are these patients who have the pulmonary complications after, like who have increased risk of pulmonary complications after surgery? These are the elderly patients who have chronic lung disease, cigarette smokers, congestive heart failure, and dependent functional status. So these patients have we have to perform pulmonary function tests like the spirometry thing in these patients to evaluate for the pulmonary functional assessment. Okay, then there are some factors which decrease the respiratory. So like for these patients who have increased risk factors, we have to do like some proceed, like we have some factors, like we have some interventions we do in these patients with the problem in the pulmonary function, so that we can decrease the respiratory complications after the surgery. So what are these things we should do in these patients, we should consider in these patients? We should tell them to, for elective surgeries, we should tell them to stop smoking before almost 6 weeks. Okay, then we should tell them to start exercise respiratory muscles. We should also tell them to to use the bronchodilators. Okay, we should tell them to have antibiotic treatment for any suspected infection, any suspected pulmonary infection. And then also, if the patient has asthma, he should be treated with the steroids before surgery. Okay. Similarly, now renal assay, for the renal assessment for patients with who have AKI, patients who have AKI. Okay, so what to do with the patients with AKI? We know that is the most common complications after the surgery is AKI. Almost AKI is 1%. The risk of AKI is almost 1% after the surgery. Okay, so what are the risk factors that predispose this patient to the AKI, this surgery patient to the AKI? We should know that this person is under, this person will develop AKI after the surgery. What are the factors by which we can predict the things? Like, he has higher age, he has some history of renal disease, his ejection fraction in the left heart is less than 35%, heart index is less than 1.7 liter per minute per meter square. The patient has any hypertensive disease, where if there is a peripheral vascular disease, patient has diabetes, patient has and those patients who undergo emergency surgeries, okay, they also have the risk of AKI, high risk of AKI. High risk surgeries, some high risk surgeries are like coronary artery surgeries, heart valve replacement surgeries, aortic aneurysm surgeries, and liver transplant surgeries. Okay, patients with the chronic kidney disease. Okay, this was acute kidney disease, and now we will see the chronic kidney disease. Okay, it's estimated that almost 15% patients have some degree of chronic kidney disease, like presently in America. Okay, problems with the CKD patients is that they have usually the thing anemia, which is normochromic normocytic anemia, but it's well tolerated. Okay, it's well tolerated. This normochromic normocytic anemia in the CKD patients is well tolerated, but during surgery it shows us that there is the need of some intervention to be done in these patients, because they start to show their less tolerance during the surgery. They have some immune deficiency. These patients have some immune deficiency, and that's why they are at the increased risk of infections. Similarly, due to repeated blood transfusion in these patients that we carry out in chronic kidney disease patients, we have to carry out some blood transfusions, so it's very high, it becomes very tough to determine the blood group in them. Okay, chronic coagulopathy is also common in CKD patients due to heparinization and uremia. Okay, so these patients have uremia, and also they undergo heparinization, lot of heparinization in chronic kidney disease. So there is chronic coagulopathy. In chronic kidney disease, there is also opioid accumulation. If a patient uses chronic kidney patient uses some opioids, there is opioid accumulation, and also opioid accumulation during in surgeries. If we use opioids to control the pain, so he's gonna have respiratory depression due to the accumulation of that opioid, because the kidneys are not functioning well. So in these patients we do not prescribe NSAIDs. Okay, in both AKI as well as CKD patients we do not prescribe NSAIDs, because NSAIDs have direct effect on what, on kidneys. Okay, now for the investigations to be done for the renal patients before the surgery, what should we consider? We should consider weight measurement every day. We should measure the intake of urine and urine output and water intake. We should maintain the euvolemic state and renal perfusion and provide nephrotoxic drugs which are like this NSAIDs, for example NSAIDs. Okay. Now electrolytes. What about electrolytes? Electrolytes, especially potassium, calcium and magnesium, should be evaluated. BUN and creatinine should be periodically evaluated. And also, if patients, CKD patients, can use TD AVP if von Willebrand factor is if there is increase in von Willebrand factor or there is a platelet disorder. What are the indications for the dialysis in these patients? If there is increased volume and accompanied by congestive heart failure and anuria, if there is hyperkalemia which is severe, which is very severe, which can result in arrhythmias, there is a treatment resistant acidosis. In these patients we went for dialysis. Okay. Now liver function assessment in surgical patients is done by to these scores. Some scores are like, for example, child pook score, MEL score. Okay. These are the tools by which we can assess the liver function. Most common, first we have to know some common problems, which is most common functional liver disease is non-alcoholic fatty liver disease, then followed by alcoholic hepatitis, followed by chronic viral hepatitis. So for paraclinical assessment, if there is no suspicion of liver disease, we do not suspect any liver disease, we do not perform any test. Okay. But if there is any suggestion or any symptom which predicts towards or which suggests to the liver disease, assessment is done. Okay. In these patients, if there is any symptom. Okay. For biochemistry and serology of viral hepatitis, autoimmune hepatic disease, metabolic disease, okay, we should do these tests, biochemistry and serology for these things, for viral hepatitis, for autoimmune hepatic disorders and some metabolic. USG abdomen is done, MRI or CT scan can also be done, but biopsy is a gold standard to reach any diagnosis related to the liver. What are the contraindications of elective surgery? For example, if a patient has a liver disease, what are the contraindications for the patient? If the patient has acute liver failure, the patient has acute kidney injury, acute viral hepatitis, acute alcoholic hepatitis, cardiomyopathy, hypoxemia, and severe coagulopathy even after the treatment. Okay. So these are the patients in which it is a contraindication to perform surgery. Okay. Now what our tools which help us to assess the severity of the problems with the liver. So first we will start with the child pook score. Child pook score is there are 5 main parameters which are to be considered. So these are serum bilirubin, serum albumin, prothrombin time, ascites if patient has ascites, so the severity of the ascites, and also the encephalopathy, severity of the encephalopathy. Okay. Now we will start with severity of the encephalopathy. 1 is given to none, score 1, 2, 3. Okay. First of all, we have to group it based on the number, how much points it get, and the severity of that class. Okay. Class A is 5 to 6, patient gets 5 to 6 points. Class B is patient gets 7 to 9 points. Class C is patient gets 10 to 15 points. If in class A, it's the least severe liver disease. so the patient tolerates the surgery very well. In class B, it's moderately severe liver disease, so the surgery can be performed except some problems if if except some surgeries like he has major abdominal or major like cardiac surgery. So except this surgery, other surgeries can be performed. And also class C is 10 to 15 points and is the most severe kind of liver disease. And in these patients, the surgery is totally contraindicated. Now we started with the encephalopathy, severity of the encephalopathy. If one, it's none. If it's like mild to moderate, it's grade 2. It's severe, it's grade 3. Okay, like it's given the point 3 points if it's severe. Similarly, ascites severity, if there is no ascites, 1 is given. If there is mild to moderate ascites, 2 is given. And if there is severe ascites which is refractory to diuretic use, we give the 3 score. Similarly, serum bilirubin, if it is less than 2 mg per deciliter, 2 to 3 mg per deciliter, and greater than 3 deciliter, and we give accordingly the score to these values. Okay, similarly, there is a serum albumin level which is measured in gram per deciliter. If it's greater than 3.5 grams, it's given 1. If it's 2.8 to 3.5 grams, is given 2. If it is less than 2.8 grams, it's given 3. Similarly, there is a prothrombin time PT. Okay, if it's seconds prolonged less than 4, 4 to 6, greater than 6. Okay, and also international, if we see by INR, we see that there is less than 1.7 to 2.3 and greater than 2.3. So we give them the scores. This is the child post score. And similarly, the MELD score is also based on 3 criteria, which is serum bilirubin, serum creatinine, and INR. Okay, creatinine was not present in child post score, but in MELD score we consider serum creatinine in cirrhotic patients, and the score is between 6 to 40. So in laparoscopic cholecystectomy, if we have to perform laparoscopic cholecystectomy in patients, a MELD score less than 8, the patients have almost zero risk. Okay, it's less than 8, the patients have zero risk of death. Okay, but if its MELD score is more than 8, the patients have like 6% risk of the death. For other like surgeries like abdominal, orthopedic, or cardiac surgeries, the score of less than or equal to the 7, okay, the death occurs in 5% patients. If the score is 8 to 11, it occurs in 10%, and if it is 12 to 15, the death occurs in 25% of the patients. Okay, now what are the problems in the patients? What are the actual problems in the patients who suffer with the liver diseases, liver disorders? The problem is that the patients have ascites. Okay, the patients have ascites. Okay, the patients have ascites. For example, what are the what complications does this ascites cause in surgical patients? It causes wound dehiscence, it causes abdominal herniation, and also the respiratory distress when the ascites are huge and it presses on the diaphragm and cause the respiratory distress. So that's why before surgery it should be managed, diuretic should be given, or TIPS should be performed. TIPS is a surgical procedure which should be performed to resolve these ascites. Decreased salt consumption should be prescribed, which is less than 2 grams per day, and give spironolactone and furosemide to the patients. These are the diuretics which should be given. Acids can also be extracted during surgery if anything is remaining, like we are doing surgery in a patient who had ascites, and if any ascitic fluid was remaining, that can be extracted during the surgery also. And alcohol withdrawal. What's the problem with alcohol withdrawal? In alcohol withdrawal, we know there are mild symptoms, there are like moderate symptoms and severe symptoms. Mild symptoms start 1 to 5 days after quitting alcohol. Okay. Major symptoms are like hallucinations, tremors, agitation, and tachycardia, which reach peak at the day 3, even after if alcohol is even if it starts 10 days after cutting the alcohol. It means that if these symptoms start 10 days after the alcohol, on the 10th day after quitting the alcohol, they reach peak at 3rd day. Like for example, on 10th day, these are like major severe symptoms. Okay, mild symptoms are not that much important. So these agitation, tachycardia, hallucination, tremors reach peak at, for example, if it started at the 10th day, 10th, 11th, 12th. On the 12th day, it will be at peak. That's 3 days of the start of these symptoms. They reach peak after quitting the alcohol. One of the severe symptom of alcohol withdrawal is delirium tremens, and if it's not treated before the surgery, the risk of death is almost 50%, and if it is treated, then only 10% risk of death is there present. So for management of this delirium tremens after the person quits alcohol, we give them with prophylactic benzodiazepines. So third thing due to this liver problem is bleeding occurs. Okay, why does the bleeding occur? Because there is decrease in formation of coagulation factors in these patients, because coagulation factors are made in the liver. Okay, like also there is vitamin K decrease in vitamin K reservoir, and there is because of malnutrition. Okay, due to malnutrition, and also number and function of platelets decrease. Okay, why does this decrease? Because in liver disease patients, there is a portal hypertension, hence sequestration of the platelets in the spleen, and also the bone marrow suppression if the person was taking alcohol. Okay, malnutrition. Also there is another problem in liver disease patients. There is this malnutrition, protein energy malnutrition. Cholestatic patients are under risk of fat soluble vitamin deficiency. Okay, if there is cholestasis in the liver disease patients, their fat soluble vitamins are not gonna be absorbed by them, hence the deficiency. If the patients with alcohol liver disease have decreased thiamine, which is the most probable thing we can say, that the patients with alcoholic liver disease have decreased thiamine, decreased folate, and decreased magnesium, and also decreased potassium, and thus to prevent these disorders, to prevent any disease during the surgery, and prevent their glucose, thiamine, folate, magnesium are important for glucose metabolism. Similarly, potassium is important in heart, can cause arrhythmias if there is some imbalance in potassium. So arrhythmias, these compounds should be replaced quickly. And if thiamine is not, and how should we replace this? First of all, if thiamine is not administered before giving glucose, patient may develop Wernicke-Korsakoff syndrome, which is characterized by a triad, which is ataxia, ophthalmoplegia, and confusion. That is, we should give the patients first with thiamine and then with the glucose. Okay. So in some conditions like this, where the problems which liver disease patients underwent during this surgery. Now after now for the condition, some conditions in surgery which has diabetes during the surgery, like how can we how to control or manage this diabetes with surgery. Okay, the complication of, first we know the complication of diabetes is gastroparesis. There is increased risk of infection. Okay, because there is because hyperglycemia especially inhibits the phagocytosis of the lymphocytes. Okay, delayed wound healing because diabetes involves small vessels. There is a small vessel problem in diabetic patients. That's why there is also a delayed wound healing. Now when a patient undergoes surgery, there is a diabetic patient undergoes surgery, there is an increased risk of infection, and there is due to the infection, and also due to infection there is increased risk of ketoacidosis and hyperglycemia. Okay, so taking increased insulin, so the patients take increased so that or physicians tend to give more insulin to the patient, which increase the risk of hypoglycemia. How to take drugs during the surgery period. Okay, how to take diabetic drugs during the surgery period. First, if the patient has been taking oral diabetic drugs, we know these are long effecting drugs and short effecting drugs. Long effecting drugs should be stopped before 48 to 72 hours of surgery. That's 2 days before surgery. Long effecting oral anti-diabetic drugs should be stopped. For short effecting drugs, we just stop them the night before the surgery. Okay, now if the patient has been taking the insulin, we know that it is medium or long acting insulin, which are usually taken at the evening, and there is also fast and short acting insulin. For medium and long acting insulin, which patient usually takes at the evening, 2/3 insulin is only given just at that evening. Okay, like if the patient takes 14 units, or if the patient takes 9 units, only 6 has to be, like 2/3 has to be taken. For example, 9 units he is taking, we give him only 6 units. Now for to stop the night for fast acting or short acting insulin, it should only be stopped the night before the surgery. Okay, 50% of normal morning insulin dose should be taken if a person is taking morning dose of some insulin 50 units, only 25 should be taken in the day of surgery that morning. Okay, so diabetes control in the surgery patients is done by sliding scale method, which is a standard way of controlling blood sugar in patients by giving subcutaneous insulin. In sliding scale method, we give subcutaneous insulin. IV insulin infusion. Another method is IV insulin infusion. There is a continuous IV infusion of insulin with the dose of 1 to 3 units per hour. Most commonly used in brittle diabetes, that's resistant diabetes. Target, and what should be the target in a patient who has to undergo surgery? The glucose target in diabetic patient should be almost 120 to 180 milligram per deciliter. Thus, to maintain this, we give 10 gram glucose per hour with continuous infusion of 10 gram glucose per hour with 5% dextrose should be given to the patient to maintain this target range of 120 to 180 milligram per deciliter. What should we check? Glucose during surgery or 6 hours after the surgery. Also, and every 6 hours after surgery. Like during surgery we check the glucose, and every 6 hours after surgery we check the glucose. Also we have to monitor the like carbohydrate amount which is to be given to the patient, because also for diabetic ketoacidosis does not depend on amount of blood glucose present, but the lack of the insulin. Another condition which we come across is adrenal insufficiency. Patients with adrenal insufficiency who have been taking like 20 mg prednisolone daily for 3 weeks, they are at risk of the adrenal insufficiency. Okay, we know like adrenal insufficiency in the surgery patients is that those patients for any disease who have been taking 20 milligram of prednisolone daily for 3 weeks are at risk of adrenal insufficiency after surgery. How should we manage it? Like the management is based on, they use this normal doses of prednisolone or steroids, whatever they are taking. The dose should be used every day morning, and then if there is a minor surgery for an abscess release or simple surgeries, there is no additional steroids are given. But if there is a procedure or there is a surgery which has moderate risk, for example hernia patients, inguinal hernial patients, the 50, if there is like a normal steroid dose and plus 50 mg hydrocortisone intravenously before surgery, and then 25 before surgery is to be given, and then 25 mg hydrocortisone every 8 hours for 24 hours. Okay, then continue the routine dose. Major, what is the if there is a surgery which has major risk for thoracic or intrathoracic surgery or major abdominal surgery, and instead of 50 mg 100 mg IV hydrocortisone is given before surgery, and then 50 mg is given every 8 hours for 24 hours, and then it's this 50 mg is decreased by half every day to reach to the routine doses like which the patient had been taking already. Then there is another condition in the surgery which is pregnancy and surgery. Pregnancy and surgery, which the best time a pregnant woman should undergo surgery is second trimester. Okay, T2, second trimester. First of all, we should know some anatomic and physiologic changes which occur in the pregnant woman. There is a location change of appendix, and it is pain due to the increased size of the uterus. There is also decreased venous return in supine position because uterus just sits above the vena cava, inferior vena cava, and there is decreased venous return if the pregnant woman lies in a supine position. Then due to pressure of uterus on the pelvic vessels, hemorrhoids are also commonly seen in pregnant ladies. Now there are some physiologic changes which occur in the pregnancy, and these are increased risk of thromboembolism due to hypercoagulopathy and lack of mobility. Okay, patient is not mobile, like the pregnant women are not more mobile, like they are not working more, and they usually tend to be like sit at a place for long hours, so there is high risk of thromboembolism or DVTs in the pregnant patient woman. There is increased contractions of heart, and heart rate is also increased. Okay, plasma volume compared to RBC volume is increased. Thus plasma volume is increased, so due to which means that hematocrit decreases if plasma increases. If plasma increase compared to RBC, it means that hematocrit increase. There is a leukocytosis in patients, in pregnant patients. There is a respiratory rate increase because of partial pressure of carbon dioxide is more, so they tend to breathe more frequently, so respiratory rate is increased. There is increased risk of atelectasis and lung complications after the surgery. If the progesterone effect is that on smooth muscles, there is delayed gastric emptying. Progesterone effects on smooth muscles, it relaxes them. Okay, so there is delayed stomach emptying, which results into the GERD, esophageal reflux disease. Best time we know that is second trimester, and trocar should be used. Trocar or those long handled things which we use during laparoscopic surgeries, and these should be used carefully. And also less, if there is some laparoscopic surgery, less carbon dioxide should be pushed into the abdominal cavity, peritoneal cavity of these patients, of the pregnant females. Now, what are the indications for surgery in pregnancy? If a pregnant patient has underwent some trauma, what are the indications that pregnancy should be surgery should be immediately done? If there is intraperitoneal hemorrhage, if there is some hollow viscera injury like intestinal injury, and if the penetrating trauma occurred to the abdomen, or there is trauma to uterus or fetus. Okay. And in all pregnant like ladies which underwent some trauma, if they are RH factor negative, the RH immunoglobulin should be given. Tubes in the surgery. Tubes in GIT system, tubes in respiratory system, tubes in urinary system. In GIT system, some tubes are nasogastric tube, nasoenteric tube, gastrostomy tube, and jejunectomy tube. In respiratory system, there are chest tubes, tracheal tube, endotracheal tubes, and tracheotomy tube. In urinary system, there is Foley's catheter, there is nephrostomy tubes. And tubes which are used in surgery are closed suction drain, stump suction or Dewel drain, Penrose drain, or which is also a passive tube, also for example a pigtail catheter. And also for fluid and abscess drainage, there are these pigtail catheters which can be used. Then wound or incision management. How we manage this? We know that wound healing occurs in different ways, like primary closure or secondary closure. Incision can be healed these ways. In primary closure, we know the lips of the two sides of the wound are stable or sutured close in close proximity to each other. And on secondary closure, we know that wound is kept open and just gauze is kept over this over the wound, over the incision, just to clear any excretions and prevent abscess formation. Okay, so gauze should not be kept tightly so that ischemia should not occur, and hence we can use 25% acetic acid, sodium hypochlorite, and povidone iodine creams over these secondary closure. And secondary closure is mostly done for those incisions or in those surgeries which have the risk of infections. Okay, which have the high risk of infection, surgical infection. For the pain management, we know we give analgesics after the surgery till the patient can start eating orally, so that we can start with the oral analgesics. In ICU, we don't know patient has pain, or patient can't talk to us about the pain. So in ICUs, we give continuous infusion of the narcotics with obviously with continuous monitoring for this, for if there is some respiratory depression occurring. Okay. Now another thing is the how we prevent the. We know that surgical patients are at risk of DVT, developing the DVTs. So DVT prophylaxis. In case of no prevention, 25% patients undergo thromboembolism. Varidi. Venous thromboembolism. If there is no prevention after the surgery, 25% develop thromboembolism. Okay. Risk factors are obviously patient doesn't move. Also there is hypercoagulopathy, suppression of the fibrinolytic system, and also the endothelial injury. Non-mobile patients with the congestive heart failure and malignancy, pelvis or joint replacement surgery, fracture of vertebrae, pelvis or long bones, because these predispose patients to non-mobility as the patient is non-mobile. Then post-operative complications are some of the complications are atelectasis, like wound is not healing, there is a fever. Atelectasis almost occurs in 90% of patients with general anesthesia who have underwent general anesthesia. Clinical features are at day 1 to 2 there is a fever greater than 38 degrees Celsius. After surgery is done in these patients, in 1 to 2 days after surgery the atelectasis occur, and most common symptom of atelectasis is fever in the first and second day. There is a positive chest X-ray of collapse showing consolidation over the collapse, infection in smear or sputum culture. Pathogenesis of atelectasis, we know that patient is not able to do deep coughing or breathing. Patient is not able to clear his or her bronchial or respiratory excretions, and there is a mucus plague which forms in the airways, and absorption atelectasis can also occur. Increase in shunt and decrease in V/Q, ventilation and perfusion ratio, results into hypoxia. Susceptible factors are sleep disorders due to anesthesia, pain at site of surgery, cough suppression, non-responsiveness of the patient, and things present in nasopharynx, some excretions or anything present in nasopharynx. Management should be done that we know that before 8 weeks the patient should stop smoking. Physiotherapy of the chest should be started, incentive spirometry should be started, and less volume surgery should be performed. Controlled pain, quick ambulation, and respiratory physiotherapy and suction of respiratory secretion should be done in these patients to prevent them from undergoing atelectasis. The non-healing of the wound, that's the wound is not healing, is also known as the dehiscence. Okay, if the incision opens up and the serous fluid comes out of that wound, it's known as dehiscence, and it's mostly due to the defect in fascia closure. We did not do the perfect fascia closure. The other cause can be like mechanical forces, infection in the wound site, and also defects in biological response to the wound. That's wound healing is not occurring. Presence of deep infection, for example abscess under diaphragm or pelvis, or between the intestinal loops also cause the wound not to heal correctly. Then fever. If there is 38.3 degree temperature after surgery, we must find out the source of the infection or source why the infection is occurring, and there is the fever. Tests are not like we can do it by doing physical examination or taking history, and necessarily all tests are known to be done, but patients who were on mechanical ventilator for a long time, and patients who are immunosuppressed, and patients who have some indwelling devices for a catheter or some artificial valve or some drains. In these patients we can do some laboratory tests or cultures can be taken. At last, the must remember points in this chapter was that if there is a patient, as a patient, and if tests of an if there's an asymptomatic patient, if the tests of an asymptomatic patient in the last 4 months are normal, there is no necessary to repeat those tests which are normal within the 4 months. The cardiac evaluation is not necessary in patients with low risk. In smokers, it should be noted, and it should be noted that they should quit this smoking at least 6 or 8 weeks before some elective surgeries. In patients with chronic kidney disease or acute kidney disease, we know that NSAIDs are not recommended, and dialysis in the patients are if there is volume expansion with congestive heart failure and less urine output. And second is with the life-threatening, the patient have life-threatening hyperkalemia or treatment-resistant acidosis. Other thing is contraindications for elective surgery in liver patients. Like, what are the contraindications in the liver disorder? If they have acute liver failure, if there is acute kidney failure, if there is acute viral hepatitis, if there is alcoholic hepatitis, cardiomyopathy, hypoxia, or severe coagulopathy. And these are the contraindications for elective surgery in liver patients. And also we have said that to assess the function of liver, Child-Pugh criteria is used, and to know the severity of the liver disease, Child-Pugh criteria used, which utilizes 5 these factors, which is serum bilirubin, serum albumin, PT, the severity of ascites, the severity of encephalopathy. MELD criteria are based on the following 3 criteria: serum bilirubin, serum creatinine, INR. Medicinal control of ascites by limiting salt intake to 2 grams. It is done during the day along with the prescription of, like, if we have to control the ascites, salt intake has to be limited. Spironolactone and furosemide are prescribed. Some complications of diabetes in surgical patients are gastroparesis, that's decreased gastric emptying, infection, and also delayed wound healing. 11th point is standard methods of sugar control in surgical patients is sliding scale method, in which we give subcutaneous insulin. Target glucose is 120 to 180 ml per deciliter, for which we can also use 5% dextrose infusion, IV infusion of 5% dextrose. Fingertip glucose level during surgery and then 6 hours after surgery should be checked. Minor surgeries such as inguinal hernia repair do not receive extra steroid dosage. Okay. In lower limb revascularization or total joint replacement, we know that 50 mg intravenous hydrocortisone is given, and then every 25 mg every 8 hours is to be given and 50 mg is given before the surgery, and then after surgery 25 mg of steroids are given every 8 hours for 24 hours, and then patient is again told to continue the normal dosage he has been taking or she has been taking. 100 mg IV hydrocortisone is given only in patients before anesthesia who have like high risk surgery or major surgeries, for example esophagogastrectomy or proctocolectomy. Then 550 mg should be given. Then after the surgery 50 mg is given every 8 hourly for 24 hours, and then this 50 mg is like reduced every 8 hours by half till we reach that level the patient already had been taking, and continue with that. The best time to perform elective surgery during pregnancy, second trimester. The jejunostomy tube is used for long-term feeding. Indications for drains are if there is some liquid or fluid accumulating or has the potential to accumulate, like empty body spaces or fistulae, we use the drains in them, or if there is abscess cavity, we use the drains. Now the most common causes of fevers in first 2 days of surgery is atelectasis, and we know the atelectasis how it occurs. Then some ways used to reduce atelectasis of surgeries are smoking stop before 8 weeks, respiratory physiotherapy, incentive spirometry, pain control, especially with the help of epidural anesthesia, and early discharge so that patient can start to walk early. So this was the chapter, and next chapter will be the fluids in like fluid resuscitations and all kinds of fluids used in surgery. Thank you.